So, ladies and gentlemen, after this introduction, I'll give the floor now to Professor Denis Poddubnyy. As said, he's from the Charité University Hospital in Berlin, and the title of his presentation is Clinical and Imaging Considerations. Dennis, the attention is yours.
Good morning, ladies and gentlemen. Here are my disclosures, and I would like to start my talk with this picture illustrating the continuum of axial spondyloarthritis. We understand the disease as a whole, as a disease consisting of two stages. The initial stage, so-called non-radiographic stage, this is a stage where we have clinical symptoms. We might have inflammation in the spine and the sacroiliac joints, but we do not have structural damage in the sacroiliac joints and in the spine. And over time, a certain proportion of patients might progress to so-called radiographic stage, where we have structural damage in the sacroiliac joints and maybe in the spine. And at this stage, the disease is called radiographic axial SpA, and older term would be ankylosing spondylitis. Both these disease stages are covered by other classification criteria for axial spondyloarthritis, which are very well known to you for sure. And the very frequent question is whether or not we can use axial spondyloarthritis classification criteria for making the diagnosis. The answer to this question is actually no, for several reasons I would like to discuss with you in more details. The first point is that the aim of the diagnostic approach as compared to classification approach is totally different. With the diagnostic approach, we aim to establish the diagnosis of a disease in a clinical practice. So we have a patient with certain symptoms suggestive of the disease, and we need to apply tests to confirm or to exclude the diagnosis we suspect. With the classification approach, we try to define a homogeneous group of patients for research purposes, and normally the diagnosis is established at this time point. That is why the starting point is completely different. In the diagnostic approach, we have a suspicion of the disease. In classification approach, we have already an established diagnosis, and this is very important that prior to application of classification criteria, we have to establish the diagnosis, in our case, of axial spondyloarthritis. The role of differential diagnosis and other conditions that might explain symptoms of the patient is also different. In the diagnostic approach, we always consider a differential diagnosis. We estimate the probability what is more likely, axial SpA, mechanical problem, degenerative disc disease, or something, and so on. In a classification approach, differential diagnosis or alternative explanation of symptoms are not considered because we have an established diagnosis of the disease and we apply classification criteria. The value of positive diagnostic tests in the diagnostic approach is different and depend on test itself. Earlier diagnostic screening tests performed, even geographic region and background population might play a role. The best example is B27 positivity. In the European population, B27 positivity has a larger diagnostic role as compared to Arabian countries, to North African countries. In the classification approach, we have only few levels of parameters with different diagnostic value or classification value, and within the same level, all the parameters, they have more or less the same value. Also, value of negative test results plays a major role in the diagnostic approach. If we have a patient without any inflammatory signs on MRI of sacroiliac joints and spine, then the disease would be rather unlikely. In the classification approach, we do not consider normally negative results of the diagnostic test. And finally, the outcome, the probability of the disease presence is the outcome of the diagnostic approach. We almost never say this is a disease for sure. We can only say the disease is possible, probable, likely, very likely. In a classification approach, it is rather black and white approach where we say classification criteria are fulfilled or not with a certain level of sensitivity and specificity. Not surprisingly, the parameter we use to classify patients we use also to make the diagnosis. But what we do out of these parameters is different. So if we look into the diagnostic and classification spondyloarthritis parameters within symptoms and history of the patient, we look at inflammatory back pain, good response to NSAIDs, presence of peripheral manifestations, family history of spondyloarthritis, preceding infection is more relevant for peripheral SpA, and some extra articular or extramuscular skeletal manifestations, they do play a role. In the lab, we have B27 positivity that has normally a quite good performance as a diagnostic tool, and elevated level of so-called acute phase reactant C-reactive protein and ESR, which are positive in 50 to 60% of patients. Imaging plays still a quite big role in the diagnostic, but also in classification approach, and two major imaging procedures are X-ray of sacroiliac joints and MRI of sacroiliac joints that especially MRI would allow really an early diagnosis of the disease. In the diagnostic approach, we work with these parameters and we consider their sensitivity and specificity. You can translate the sensitivity and specificity into a diagnostic value of the test, so-called positive and negative likelihood ratio. You see here on the last two columns of this table, and the positive likelihood ratio tells you what is the value of this test if the test is positive. And you see the highest positive likelihood ratio is in radiographic sacroiliitis of grade 3, and uveitis anterior has also quite high positive likelihood ratio between the 7 as well. Negative likelihood ratio tells you what is the value of this test if the test result is negative. So how high would be the reduction of the diagnostic probability if the test is negative. And you see that there is also a major variation in terms of the diagnostic value of negative test results. And at the end, we can combine all these likelihoods in a so-called likelihood ratio product. And probably you all know this concept of a diagnostic pyramid for axial spondyloarthritis, where we can estimate the probability of the disease. We start here with 5% of the probability of axial spondyloarthritis in patients with chronic back pain, and with every positive parameter, we increase the probability of the disease. The limitation of this approach or of this presentation of the diagnostic pyramid, it's really hard to consider here negative results of the tests. Therefore, another approach might be better to imagine or to reimagine the diagnostic procedure in axial spondyloarthritis, a so-called diagnostic scale, where we can weight positive test results against negative test results. If we take all the available diagnostic tests, we can translate their diagnostic value in a relative weight. And here you see that both positive and negative test results, they have different weights. And for example, radiographic sacroiliitis has a quite high weight if it is positive, but not that high weight if it is negative. And what is very important for the diagnostic approach, that we can also put here another explanation of symptoms, more likely explanation of symptoms that should be considered within the negative test results. Just two examples on how to apply this concept. These are two patients with very similar profiles. Patient on the left is a patient with intermittent inflammatory back pain for 15 to 20 years with acute anterior uveitis, with last episode 2 months ago and another one 10 years ago. No other manifestations. HLA-B27 is positive and CRP is currently normal. A patient on the right, patient B, has almost the same profile, also intermittent inflammatory back pain, acute anterior uveitis with 2 episodes in the last year. B27 is positive, CRP is normal. So you can see here already, if you apply just a classification criteria to make the diagnosis, you might get very quickly a conclusion. In both cases, classification criteria are fulfilled, but because B27 is positive and there is uveitis and there is inflammatory back pain in a patient with chronic back pain starting prior to 45 years of age. But that would be absolutely wrong application. That would be a misconcept because we do not know what is a diagnosis in both patients, and that is why we need to move forward in our diagnostic approach. And if you look into the information I gave you, you see that imaging is missing here. So let's go to the imaging. And patient A, here you can see an X-ray of sacroiliac joints where you see some structural changes, especially on the right-hand side with some erosions. On the left-hand side, it is rather difficult to estimate because there is an overlap with intestinal gas. So I grade it as a grade 2 on the right side, grade 1 on the left side. So no definite radiographic sacroiliitis. In that case, we normally use MRI to confirm or to exclude the diagnosis. MRI was performed. Here you see a STIR image, water-sensitive sequence, where we can find bone marrow edema, osteitis as a manifestation of axial spondyloarthritis. Indeed, there is bone marrow edema in the right sacroiliac joint, and if we look into T1 depicting structural changes after the inflammation, we see that there is a lot of structural changes on both sides, fatty degeneration, also erosions, and even a backfill sign. So in this situation, we have several positive test results, and one of them is a positive sacroiliitis on MRI. Negative test results, only no radiographic sacroiliitis, no elevated CRP, but in this situation, positive test results have clear bigger weight. Patient B, we have here again X-ray of sacroiliac joints, and you see here some structural changes, some subchondral sclerosis, but it is not clear what is happening in this area. So everything is possible from grade 1 to grade 3. That is why we need here an MRI. MRI was performed. On MRI, you see absolutely no bone marrow edema, no changes in the sacroiliac joints, but there is some bone marrow edema in the vertebral body of the last lumbar vertebra, and you can see it even better in another slide. And T1 weighted image gives you even more information because there are no structural changes in sacroiliac joints. There is some new bone formation ossification of the capsule mimicking ankylosis of the right sacroiliac joints, and there is a big problem with the intervertebral disc, degenerated disc with Modic 2 lesion. So, and here on the wipe sequence, you can see it even better. So this degenerated disc and capsule ossification. So if we could go back to our diagnostic scale, we have the same positive tests, but we have here negative MRI, and what is very important here, we have another more likely explanation for back pain in this case, and that is why axial spondyloarthritis in this patient would be rather unlikely. So for patient A, we have a diagnosis of axial SpA. For patient B, it's a diagnosis of degenerative spinal disease, and that is why for patient B, axial spondyloarthritis classification criteria would be not applicable. Although imaging should not be given with an all-decisive role in the context of diagnosis of axial spondyloarthritis, it plays really an important role because in contrast to all other inflammatory disorders, we cannot visualize inflammation in the sacroiliac joints in the spine by other methods. We cannot detect it by physical examination. The problem is that active inflammation or bone marrow edema can also occur in non-inflammatory conditions as a reaction to mechanical stress, and it's even possible in healthy persons. And that is why it is extremely important to learn how to differentiate between mechanical or non-inflammatory problems, how to differentiate them from real inflammation in the context of axial spondyloarthritis. There are several potential ways. What we are doing already for years, it's a continuous educational process. We also learned a lot over the past 10 years how to differentiate between inflammatory changes and non-inflammatory changes. Central reading service for the clinical practice might be another option, especially for centers not specialized in axial spondyloarthritis. And another potential option could be introduction of the artificial intelligence, machine learning. In the next 2 minutes, I would like to show you some interesting initiatives in all three areas. The first one is an others online case library we released this year. This is a educative case library consisting of currently 20 cases covering all or almost all manifestation of axial SpA plus plenty of differential diagnosis, and every case is presented in a similar way I did it a couple of minutes ago. We start with a medical history, go then to imaging, and there is a summary explaining why we established this diagnosis and not another one. We are also working right now on a research project dealing with a potential central reading service for the clinical practice. Will be evaluated in the next couple of years, and if it is successful, it might be available for many rheumatologists across the globe. And finally, artificial intelligence. This is really a rapidly evolving field, and you might expect at this Congress and also on the forthcoming congresses many new interesting data coming from artificial intelligence. This is an example of a project we did together with colleagues from Oxford, where the machine was able to recognize active inflammatory changes in the spine as with quite good agreement with an expert reader results. So I summarize at this time point, in the clinical practice, it is really important to differentiate between diagnostic and classification approach. Classification criteria are intended for use in clinical studies and should be applied to patients with already established diagnosis after exclusion of other diseases. The true diagnostic approach considers the pretest probability of the disease, positive and negative results of the test, also potential other explanation of symptoms, and ends with a certain level of probability of the disease, while in the classification criteria we have yes or no answer. In the diagnostic workup, we use proper imaging, and we should interpret this imaging as one of the main parameters to establish the right diagnosis if we suspect axial spondyloarthritis. And new developments include artificial intelligence and central reading services. These developments are evolving right now. Thank you very much.
Well, Dennis, as we did, you also worked on NSAIDs and on the effect of NSAIDs on inhibiting radiographic progression. What is your guess? Do you really think that NSAIDs inhibit radiographic progression? And what about biological DMARDs? There is a lot of controversy, and a lot of papers have been written and presentations have been given around this topic. Do you think biological DMARDs really inhibit radiographic progression in axial SpA?
I do think that any potent anti-inflammatory drug is able to inhibit structural damage progression in axial spondyloarthritis through inhibition of inflammation, and subsequently that would result into inhibition of structural damage. It is interesting question whether or not we might have in the future drugs with direct inhibiting effects on newborn formation. As of today, we do not have a strong evidence for that. But what we see that there is inhibition of structural damage progression through inhibition of inflammation. That is why if we talk about targets in our therapy, remission, inflammation-free state is a primary target, and then if we achieve that, most likely will become also inhibition of structural damage progression for 3.